Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission to provide medical professionals with the resources they need to learn from each other and in doing so, improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics including multidisciplinary approaches to patient care and new innovations in medical technology. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org.
Today, we are joined by Drs. Ventres and Erick Messias from the Departments of Family and Preventive Medicine and Psychiatry at the University of Arkansas for Medical Sciences in Little Rock. They will be discussing adverse shared historical experiences and the influence historical trauma has on current health outcomes, a topic they addressed in their article appearing in the November 2021 issue of the Southern Medical Journal. Thank you both for being here today.
Thank you, Ms. Price. It's a real pleasure.
In your SMJ perspective, you discuss adverse childhood experiences and how the concept of ACEs has helped define risk factors for a variety of health outcomes. Before we discuss another acronym, ASHES, could you provide a few examples of adverse childhood experiences?
Absolutely. Adverse childhood experiences include, but are not limited to, interpersonal violence, family violence, abuse and neglect, witnessing violence, having a member complete or even attempt suicide. Those are some of the really most critical adverse childhood experiences that have been in the literature since the late 1990s.
Why another acronym now, especially in that social scientists already have other names for what you call ASHES, including historical or intergenerational trauma?
Why ASHES and why use an acronym? Well, I should note that while both Erick and I are in academic medicine, and Erick has moved on to be chair of psychiatry at St. Louis University, we both are clinicians. And clinicians, one, like acronyms. Two, the ideas of transgenerational, intergenerational trauma, or historical trauma, those are such big concepts that most clinicians, whether they be psychiatrists or in generalist practice, whether internists or family physicians or pediatricians in generalist practice, those are simply concepts that are too big, too overwhelming, and I should say, too frightful for us to consider. So an acronym makes it basic, simple, and changes those big concepts into something like ACEs that we can wrap our heads around.
Right, and hopefully this would help us understand some of the health disparities that we see in populations today. So the health disparities, for example, that we see if you compare health outcomes among African Americans or Hispanics or Native Americans or Caucasian Americans, what made them be what they are? So part of this is not individual risk factors. We're talking about groups of people. So to us, I think Bill was hitting at something extremely important, which is to take a concept of that is individual adverse childhood events and think about it from a collective perspective. And I think that he was really right on the money when he pointed out that this would be a useful concept to help clinicians in healthcare address populations, not only individuals.
This is very much an intriguing and interesting topic. What in your own history prompted you to explore it? How did this come about?
Erick, would you like to start?
From my own perspective, well, I'm an immigrant. I migrated to this country after medical school to be resident, and I have had, from my personal perspective, I have had a wonderful American experience. I think the experience that you want every immigrant to see, to be integrated and to be welcomed into the medical community. I have felt very much welcome, but I know this is not an experience that is shared by lots of immigrants. So from although my personal experience has been very positive, I know from reading and from talking to patients that their own personal experience as immigrants to this country has not been as positive as mine. So I've always been very attuned to the needs of groups of people that don't fit the mold of English-speaking populations, of white populations that are part of the mainstream of America. I think being somewhat to the side of that mainstream has helped me be more attuned to specific populations that have been part of the margins. And I have to say that part of my personal belief is that they are not the margins, that we are all part of the American experience as we want to build it. That is an inclusive experience that has, all these groups as part of being American. So that's my personal, that's as personal as I can get here. Bill?
And then from my point of view, first of all, I've been a family physician in urban underserved settings, worked with a lot of immigrants, whether they be immigrants or refugees. But what really struck a chord is that from 2010 to 2015, I worked and lived in El Salvador. And El Salvador is a small country in Central America. From 1980 through 1992, they experienced a really quite brutal civil war. And there were many, many people, both in civil society and in academic work, in public health and in history and in anthropology, who are trying to figure out I'll call it collective trauma that resulted from that war. It was 12 years of brutality on, let us be honest, poor people fight wars, and it was 12 years of brutality that just engulfed the country, and especially people on the lower economic margins of society. They're still dealing with that, a lot of ripple effects, and that's where I learned about intergenerational trauma, historical trauma, and that's where I actually came to see how that affected people ongoing in their day-to-day lives.
With your own perspective and personal experiences, looking at it from a clinician standpoint, how can clinicians use this type of information in practice?
So, Ms. Price, the first aspect is simply that patients bring to their clinical encounters with physicians, whether it be any kind of clinician, they bring these kinds of issues in their memory, in their character, in their psychology. And the first step is simply acknowledging that. I think in medicine, we have kind of a learned blindness. Oh, that's not real medicine, so we're going to ignore that. But I'm absolutely sure that patients are people. And as individuals, they bring both their physical selves and their emotional selves. And part of what makes up their both physical and emotional selves is their history. Our minds and our bodies are not so far apart. So that's the first step, is just acknowledging it. The second step really is being willing, and this comes on the part of the clinician, to recognize it, to spend at least some time hearing it, hearing the stories of the patients. We don't have to address it all the time, but we need to somehow recognize and acknowledge, and then recognize and allow the patient to bring that to the fore. Now, the third step is actually doing something about that. We can talk about that a little bit more. That's a little bit more complicated.
Yeah, and I would say that I'm a psychiatrist and I practice psychiatry. And in psychiatry, I'll give you a practical example. We have learned that if you compare people that have had trauma, and I'm talking individual trauma, the adverse childhood events, if you compare that population with the population that have both come with depression, but if you have the population that comes with depression without ACEs, they respond to medications. They tend to have very good response to medication. When you take the group that have had adverse childhood events and have developed depression, they respond better to a combination of medication and psychotherapy. So what does that tell me? It tells me that if I want to address these traumatic events, either on the individual level or on the collective level, we are going to do what Bill just said, which is we're going to acknowledge it, we're going to listen to their perspective, and we're going to try to. So there are several psychotherapies that have been developed for, say, post-traumatic stress disorder. So the question is, can we take some of that and bring to the practice with populations that have had these types of adverse events at the populational level? And some of those are narrative therapy. You're talking about processing trauma. You're talking about even doing something about it that Bill alluded to. So there are things that we can do differently as clinicians by knowing this, by acknowledging this, by understanding that different populations, and here I want to go ahead and mention, as we're talking, there's no way to escape the issue of race in America. So we talked about the migrant experience. Bill talked about the civil war within the country, but we have to remember that we have a collective history of slavery in the US that needs to be acknowledged at some level, that has changed populations' behavior. And to this day, contributes to different health outcomes that we see, worse health outcomes that we see among African Americans than we see among whites in this country. So I want to point that out too.
Some people, if they read your perspective in the journal, will wonder if it was written in support of some type of reparation. Is that what you had in mind? Is that what you were suggesting?
This is a tough question. Thanks for asking it. No. One of the issues with history is that we actually can't go back in time. We can listen to people's stories, but we can't go back in time. There are people who would speak to the reparations. I do think there's room for discussing that, but that's really beyond the scope of this article. And it's beyond the scope of what we, I think, are interested in bringing to the fore. We are interested in bringing to the fore how we move forward. And I learned these words just this past week: intentional inclusivity. And what intentional inclusivity, at least from my perspective, meant is that in medicine, whether it be in generalist practice or subspecialty practice of whatever kind, we need to intentionally, thoughtfully consider all the elements that add up to people's health. And we know now that medicine itself only contributes to a small part of that. And that as we move forward, looking at ashes, we need to consider, one, how we can prevent future ashes. Just in the same way that we want to prevent the kind of interpersonal violence that children have, ACEs. The second part is, how can we in medicine look to engage those people who have been on the margins? And that may be reaching out into communities, developing new ways of, again, being inclusive. And also, and this comes back to the individual, but it's also to the community, how we listen to patients and community problems, and how we accept and hear the stories, and then work with those communities, individuals and communities, and then figure out with those individuals and individuals in communities how to include them in a more health promoting society. We can't do it all, but our hope was that through ASHES, we can get people thinking and considering other ways of moving forward.
You touched on looking forward, and I mean, the past is the past. And as you discussed, all of these things did happen previously, some in the very distant past. And you touched on this, I think, just now, but if you could maybe expand, why is this relevant today?
I think the relevancy of this is twofold. One is we need to address health disparities. And traditionally, when I say this, I mean the fact that African Americans have a shorter life expectancy than whites. I think there is no reason for us to have this disparity. So in which African Americans have expect less from life than people that are not African Americans. I think that's something that we all should agree is something we need to address. And that has to do with outcomes related to cancer, kidney disease, all sorts of medical conditions that are affecting specific populations, given their historical disadvantages and oppression. Basically, we have to be frank about that. But I want to mention the other side of this. The other side of this is there are some health outcomes in which African Americans and Hispanics, for example, have better outcomes than whites. So I'll give you one example that is actually very important and is pretty significant, and there is a pretty significant difference. Is one that is close to my heart because I study it, is suicide. The suicide risk in the US is significantly higher among white people than among the minorities, actually. So can we learn from the minorities about what makes their population in their communities more resilient to suicide than the white population? So I think we have to create a two-way street of learning. I think we have to use things that we learn that can extend lifespan, that we now offer to predominantly white populations in this country. We have to offer that to all Americans, right? But we also have to look at these communities and see what are they doing right, that their level of their suicide rate is significantly lower than the white population. So I think we have to look at each other not as I have the knowledge, you need to learn from me, but that I have some knowledge that I can share with you and make your life longer and make your life healthier. But you have some knowledge based on the resilience and based on some aspects of your community that I need to learn. So my suicide rate is not as high as it is today. So I think my main point is that we need to make this a two-way street. It cannot be one population telling the other how to live. Is that we learn from each other. What is it that you're doing right? And what is it that we are doing that is working for us that may work for you?
From a little bit more philosophical point of view, I think we need to learn how to work with people rather than just for people. Second, I think that we need to figure out how to, in this two-way street, build on aspects of inclusivity, build on aspects of respect, and build on, it's been called cultural humility, but I'm going to extend that to say it's global humility. Global in the sense that these issues that Eric is talking about and that we talk about aren't just located there, but they're located right here, right next to us. And we are part of that in the medical community. And the third philosophical part is simply George Santayana's famous words: those who cannot remember the past are condemned to repeat them. And I would like to think we can learn from the past as we move forward.
This has been such an informative conversation, and you've shared just so much valuable information. And before we conclude, as you've talked about this, I mean, this has such far-reaching effect and the opportunity for change. Does what we have talked about today have special relevance to where you live and work? Being in the South, the Southern Medical Association is in the South in Alabama. So I think this affects all populations, all areas, but again, any relevance just where you are now?
Ms. Price, just listening to both of us, you know that neither of us grew up in the South. Erick's from Brazil in the deep South.
Yes.
I actually grew up in Minnesota, but I have been transient but not homeless my entire adult life. I've lived in a variety of parts of this country and overseas. But I'm in Little Rock. Now, it takes 3 generations to be an Arkansan, so I can't claim to be an Arkansan, but I can claim to be a Little Rocker. And folks in Little Rock know that in 1957, there was an incident that happened. And that incident involved the Little Rock Nine and the desegregation of Little Rock Central High School. And one would have to be blind or nearly blind to ignore the ripple effects of that today. People are working and things have changed since 1957. And Little Rockers and Arkansans should be proud of those changes. But these aren't changes that will be cured, so to speak, to use a medical term, in 1 generation or 2 generations. These are changes that are in need of daily attention and in need of that kind of ongoing work, both healing the past and developing the future.
Yeah. I mean, in St. Louis, of course, some people call it the broken heart of America. St. Louis is a city that has many challenges, and I train in Baltimore. So, and I see a lot of similarities between Baltimore and St. Louis in terms of a post-industrial city that have lost a lot of this affluent population to the suburbs and has created pockets of poverty in the inner cities. So these factors are very much alive in St. Louis, and we as Americans need not forget a national perspective. And the national perspective is these factors we discussed today are true and real throughout America, right? And if you go to the Northeast, you have populations, you have the African American experience and the Hispanic experience there as minorities that live there. If you go to the South, you have the historical grievances that still exist related to slavery and the Civil War. And then if you go to the West, you have a Hispanic population that in many places is not minority, is a majority population. If you go to the Northwest, you have the Native American population, which, by the way, is the one population that can get close to the white population in terms of suicide risk. So Native American risk factors for suicide are extremely important and needs to be better understood. And you have the African American. And then if you go to the West Coast, you have the Asian American, high concentration of Asian Americans that, again, deal with similar issues related to internment camps, related to how Asian Americans are perceived as friend or foe throughout our history. So we ought to remember that this is a continental country with several pockets. And in each one of these pockets, we're going to have different challenges related to this very issue.
And perhaps the issue isn't about the South, as Erick is saying. This is, as Erick notes, this isn't an issue just about the South. I happen to be in Little Rock. Erick happens to be in St. Louis right now, and there are issues in those spots. But this is an issue throughout the United States that takes on different tenors in each location, as he just mentioned. But this is also an issue around the world. And whether it's an issue of race or class, whether it's an issue of civil war, whether it's an issue of power or profit or prestige or greed There are so many things that draw us apart. Somehow, at least in medicine, we have to look at our work as a healing process, and we need to engage in these issues. I don't have all the answers. This article wasn't meant to present all the answers, but it is meant to get people thinking about it. And if we can do that small thing, regular clinicians who are doing the day-to-day work of caring for patients, if we can introduce them to the idea of ashes, maybe we can engage them in work of advocacy for what really is some of the major challenges of today and have been major challenges in the past as well.
I have enjoyed this conversation very much with both of you. I've learned a lot, and I'm sure our listeners will take away some very important information. Before we conclude, just finally, are there any final thoughts you would like to share with our listeners?
Yes, there is one final thought, and I'm going to read this. It's the final line of the article. Ultimately, the idea of ashes can help us focus on how each of us, independently and in concert with others, can rise up from the legacy of ashes and work toward imagining, building, and sustaining a culture of collective well-being for all. Thanks very much.
Thank you both.
We hope you enjoyed The Practice of Medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcast or subscribe to us on iTunes, Google Play, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org, and thank you for joining us today.